So we have, good morning all, I am Dr. Sumamtra. So we have already shared our Google form link with all the delegates. So if still now somebody has not received it yet, they can contact our help desk and we will collect the response within half an hour. Thank you. So we can start the session, sir, with your permission.
So before starting of the session, I am just introducing we have very expert speakers in this subject. They are well established in their field and they have numerous publications in this field. They are class academicians, they are also good organizers and they have some innovative works in their fields. Firstly to say Dr. Sumamtra Kumar Raut, he is pediatric nephrologist and he has done MD and DM in AIMS. He is presently a professor of pediatrics.
Thank you.
And in charge of pediatric dialysis unit and pediatric nephrology at North Bengal Medical College. Please, Sumamtra, start.
Sir, you can, Dipendra sir, you can ask for both the panels also.
Okay.
Introduce our panels also, please.
We have Dr. V.B. Satyaprasad. He is the senior consultant of pediatrics nephrologist and in the Rainbow Children Hospital, Hyderabad and Bajrang Hills. He has 18 years of experience in this field. His special area of interest is vasculitis, renal tubular disorders, refractory hypertension, and kidney transplantation. His major achievements is expert in renal replacement therapy and running successfully renal transplantation programs for last few years. We have Professor Mihir Sarkar, who is a professor of pediatrics and head of the PQ unit of Medical College, Kolkata. He is a teacher of College of Pediatric Critical Care, India, and chairperson of Society of Pediatric Intensive Care, Kolkata. He is also vice chairperson of Pediatrics Pedisters India and joint secretary of West Bengal Academy of Pediatrics. He has 14 years of experience in critical care. He has 47 publications, 22 international and 25 national.
Slide. Sure. Time start. Thank you. So we are going to start our first panel discussion of our opening ceremony of our ISPN Con 2023, and welcome all once again to all of you in the city of Joy. And with this August morning, with little bit of technical glitches, I agree. But we start our first session on a crosstalk, which is most important in our day-to-day life in critical care units, where pediatric critical care is most important one. So as we all know that AKI is pretty common in our day-to-day pediatric practice as well as in our critical care units. It's around more than 25%, and obviously the severe AKIs are more than 10% in our regular PICU practices. And among them, it hampers the mortality, it hampers the morbidity, and whoever requires a KRT are having a high mortality rate. So the AKI just not only it hampers the fluids or electrolytes imbalance, but also it targets all other different organs. And so different organ masters most of them are required to manage a kid well. So without wasting my time, I have both my very senior doyens on the field, Professor Mihir from PICU team and Professor Satya from pediatric nephrology team. So we have some real practical case scenarios, how to tackle the scenarios in our day-to-day practice. Just we can have a quick go through by two cases. So our first case is Ankit. It's a 7-year boy. Is admitted in PICU with meningitis. The BP is just holding 78/48 after getting 2 normal saline boluses. So probably a septic shock and seems to be a little bit volume responsive. So our direct practical problem we face that does this child need more boluses? If so, how much? 3rd bolus, 4th bolus, 5th bolus, or how many? And if after completing all the boluses, if still is volume responsive, after that we are going to start the inotropes, or maybe we can start our inotropes a little bit prior, even if completing the boluses total. So the question directly to our PIC in charge, Professor Mihir sir. So sir, can you briefly ask that?
Yes.
Thank you, Dr. Sumamtra, for this question. So, this patient you can see is the patient with the septic shock with the meningitis, already received the 2 boluses at present, just holding the blood pressure. Okay, it may be that already got the 2 bolus. I presume it will be the 20 ml per kg 2 bolus. That may be already we have given the more fluid to this patient. I don't know the other parameters or the other status to this patient. If you can look at this diagram here, so it is septic shock is not only the volume deficit, so it may be the deficit or the problem in the cardiac contractility, it may be the difference in the tone of the peripheral vasculature, so it is a combination. So this functional septic shock family, it may be the preload deficiency, it may be the contractility, or it may be the vascular tone. So you have to assess and you have to address everything, not only the fluid. So you may need ionotropy at the same time, you may need the inodilators, or you may need the fluid at the same time. Next, please.
Okay.
Yes, next. Yes.
So then how to decide?
Yes, so reading the fluid in patient in septic shock, yes, that now the evidence is, especially after the FIST trial in Africa, you know that we are going for the more restrictive fluid resuscitation in the patient. With the patient, you are sure that the patient is septic shock. First bolus, you can give the hypotensive shock at 20 ml per kg, but next bolus onwards, the alicot should be lowered at 10 ml per kg. And further bolus should be earned, that you cannot just blindly give the bolus, the patient is only hypotensive and not reaching the your goal. Okay, so you have to assess the fluid responsiveness and fluid tolerance at the same time of the patient. What we do in our daily practice, we use the point of care ultrasound more frequently. And next, please. And if you look at this, if you give the more fluid to the patient, unjudicious use of fluid, that may lead to increase the rescue ventilation, rescue inotropes, and even the dialysis and CRRT and longer ICU stay. So if you can start the inotrope early, that will lead to reduced need of the reduced fluid overload, reduced need of improve the urine output and the improve clearance of the lactate, and decrease utilization of the ICU resource like the ventilators or the KRT therapy. So if you, last part of your question, if you can start the inotrope at the same time, yes, from the first bolus onwards, you can start inotrope. And even you can start in the peripheral line, not it is required the central line. So in the peripheral centers also you can start. So this is the study, landmark paper published in Lancet by 4 authors are from India. And they have mentioned here, next slide please, if you look at the first row with the fluid bolus, simultaneously if the patient is hypotensive, depending upon the hemodynamic status, if it is a vasoconstricted or vasodilated shock, you can start epinephrine or norepinephrine in this patient. So message is clear. So it is not the fluid. Assess the patient, what is the contractility, what is the vascular stone, and start inotrope early, and if you can start in the peripheral line as well.
Okay, so after getting a little bit new lessons that we are going little bit guarded on our boluses and starting our inotropes a little bit early. So we did it the same. So we have completed 2 boluses. The child is currently on 2 inotropes. Now we got the biochemistry is mostly very high total counts, very high C-reactive proteins such as high ferritins as well as high pro-BNP, suggesting multi-system inflammation is going on. The urine output now started dropping, and the BP is still marginal. So now Dr. Mead thought that it's be prudent to give a call to Dr. Satya now, but the resident just wrote these 4 lines, no more details. So Dr. Satya now came for a visit to the IPICU. So sir, what's your question now? So what do you exactly, Dr. Mead, what do you exactly want from Dr. Satya? What points do you want to get a help?
Yes, so you can see that the patient further progressed and it is not a good shape. So the patient is just holding the blood pressure marginally, even with the 2 boluses and the inotropes. And the urine output at the present moment, I can take it, we can consider it as or we can take it as 0.7 ml per kg. I'm not much worried about that, but there is, I'm worried about the fluid overload. It is already 10%. So that increases the mortality and the outcome. And inotropes dose, it already 3 inotropes, it may be the higher dose, and the patient having hyperinflammatory states, and electrolytes at the present moment we don't know. So at this moment, I need some space for volume or the nutrition or the drugs to be given to the patient. Same times I want to reduce the fluid overload, and the same times I want to reduce the, because you have already mentioned the hyperferritinemia, high CRP. So if it will be good if we can restrict this hyperinflammatory inflammatory state a bit to this
Correct.
patient. Okay, so that will be our take from the nephrology. So if we can remove the fluid without hemodynamic instability, if we can give some space for drugs and space for and remove the cytokines.
So now Dr. Satya has been understood a little bit that what the critical care team actually required from him. But now, Dr. Satya, what do you extra information required other than these lines which was written on the refer paper? There are only 4 lines written, that's all.
Yeah, thank you, Dr. Sumamtra. Here we know the history now. We know the background history and clinical status of the patient. Apart from the investigations we have done, we need baseline renal function,
Correct.
urea, creatinine, electrolytes, calcium, phosphate, along with acidosis, whether the child has acidosis or not. We have to do blood gas. And along with that, we have to see whether child has any deranged coagulation, LFT, PT, APTT, and already child has fluid overload.
That's
So here, child has sepsis also. We should know the cardiac contractility. So we should know the ejection fraction because of sepsis, whether child has any poor contractility. And as already we have done few investigations, renal functions, we can see urea 160 is quite high. Creatinine is also high here. And sodium is okay, potassium is okay, calcium is bit low, 0.9, phosphate is normal. But child has bad acidosis.
Right.
And pH is 7.13 with base deficit of -14. And with bicarb of 9.6 and lactate is quite high.
So our PQ team
4.6.
informed the report that was deranged RFTs
Yes.
along with borderline high potassium with the metabolic acidosis, probably a high iron gap, chloride not mentioned, and obviously deranged RFT,
Yeah,
deranged bleeding profile.
Yeah.
So now
here,
Our point is how to go advance with this. Does we thinking of starting our KRT now on this child? And if yes, which modality preferably?
yeah. So here usually the indications in this patient, child has fluid overload, anisotropy support, marginally BP is okay, but still requiring 3 inotropes.
Okay.
And acidosis is bad with rising lactate. And child has sepsis also with cytokine storm, hyperinflammatory state.
So other than fluid overload or as Dr. Mead told, we need some space because we need to give some antibiotics, infusions, inotropes.
Yes.
A huge volume with 100 ml of urine only. It can't be possible. Maybe a 500 or 600 ml of intake we need to do even if we are not fulfilling the nutrition for first 2 days. And moreover, what Dr. Mihir is expecting that the child is going into early part of sepsis where he wants, if possible, to remove some cytokines by some extracorporeal therapy. So that's
Here-
why Narasata suggests
Yeah.
that we need
Here
to
the
start the
indication
KRT now.
is, so importance of dialysis here. One thing is removal of fluid so that
Correct.
intensivists can give more fluids,
Right,
they
sir.
can accommodate more fluids. Not only in fluid removal, even infection.
So what would the modality
So we
which
can
we
remove
choose here?
endotoxins and inflammatory markers we can remove
Okay, fine.
during CRRT or
By which
PRRT.
modality then?
Yeah.
By which modalities of KRT? we use here?
Usually child is having sepsis with this site of picture. Always is better to do CRRT, either CVVHDF
Fine.
or PIRT. If you don't have any facilities, resources, you can go for even peritoneal dialysis.
So the ideal treatment is CRRT. If it is a resource limited
Yes.
setup on, then PD can also do more or less the
Yes,
same
PD
job.
also you can
Fine.
do. And if you have really resources, if you can use cytosol or oxidase
Right.
early, that is quite useful. Any child with sepsis, multi-organ dysfunction,
Right.
if you start early CRRT along with heme absorption with cytosol,
Right,
you will get very good results.
And particularly this auxiliaries came after a huge blow after this COVID era, and obviously Rupesh sir and other seniors are there who has a lot of experience of using these auxiliaries in pediatric populations. So coming to our second case, on the same tone, such similar patient. So this is Misty, 80-year-old girl. She is also admitted in our ICU with rapidly progressing glomerulonephritis, with respiratory distress, probably a cardiac failure-like features, has general tonic-clonic seizures. The blood pressure was too high. Now she is a bit drowsy. She is on face mask oxygen. We heard some gallop, and there was elevated jugulovenous pulse. So this was the X-ray for her, and that's showing bilateral bat wing opacities-like features. So Dr. Satya was a little bit out of hospital. She is in town, but out of hospital. So now Dr. Mihir has the whole burden to take on his own shoulders. So how to manage this kid till RRT can be starts. So Mihir, how to tackle this one?
Yes, so first of all, this patient has having the hypertensive emergency with the heart failure and the pulmonary edema that needs some, before the dialysis, we need some supports for this patient. So we have to restrict the fluid in terms of the 40 to 50% of that maintenance and then titrate according to the urine output you are getting. And judicious use of diuretics, we can use it up in this patient because this patient needs to reduce the pulmonary edema. I will prefer for furosemide infusion to this patient. And non-invasive ventilation will be helpful for this patient because it will help to reduce the work of breathing as well also reduce the afterload for the heart, left ventricle, and also improve, help in the reduce the pulmonary fluid drainage. And the antihypertensive, yes, I need the cautious use of very short-acting antihypertensive like sodium nitroprusside under invasive BP. So that is the important, you need to have a invasive BP monitoring here.
So whenever the child starts on an AKI in our ICU, so we start with our AKI regimen for fluid restriction, that electrolytes has to be taken care of. And even if we fail such thing, most of our setups are doing just rescue indication of dialysis because it may vary that we can start our dialysis early. Whenever the child's eGFR drops, there is a AKI stage 3 or maybe AKI stage 2 plus 8 hours or 10 hours. This type of trials, adults has already made it, and that has shown both the directions the results are going on. So mostly in India at least, most of the centers are following rescue type of dialysis, means whenever the acidosis, hyperkalemia, fluid overload are going beyond our hands, beyond the medical management part, that time we think of starting RRT in most of the scenarios. So now despite the Lassie's bolus, the heart failure didn't improve much. So now Dr. Mihir again asking Dr. Satya to extend the help. So now Dr. Satya, for this child, what modality we can offer with our best, with having an acute heart failure?
Yeah, this child basically has azotemia with fluid overload and hypertension encephalopathy. Obviously here one thing is you have to remove fluids. At the same time you have to correct acid bases and hyperkalemia also. And we have to control blood pressure also. We have to bring down blood pressure.
Correct.
The ideal way is by doing hemodialysis, which is intermittent hemodialysis.
Right.
And this one we can do, and here there is no role of any CVVHDF. This is an acute condition, which is an emergency,
Right.
which requires rapid electrolyte correction.
Fine.
So we have to do short section of dialysis, only which should last for few minutes, half an hour, 1.5 hours to 2 hours.
Right. So the gross difference between the first case and second case is the first case was hemodynamically unstable on 2-3 inotropes. So we can't do intermittent HT on that child. So we need a gentle process, so that's why CRRT, otherwise PD. But what this child sees in acute heart failure, we need something which can drag out the fluid very rapidly. And the BP is stable even if high, so we can take out fluid as early as possible. That's not an issue. So for this child, CRRT will be a prolonged process. The heart failure will take maybe hours to recover. So we need something which can be done rapidly. Again, if facility exists, then intermittent hypo is the best choice, as Dr. Satya told. Or maybe in resource limited setting again, we can start doing PD, but there are some changes in the PD precision to be done to make it a rapid process. We will come into that on our next hands-on session also. So now this child was decided to go for intermittent hemo. And as Dr. Satya told, that intermittent hemo will be for very short duration. Usually our standard hemodialysis precision is for 1 hour on first session is 1 hour. But here we will check how Dr. Satya approach for this. So first, how to make an access, because the previous child, which the case 1 has a deranged RFT, so deranged coagulation profile, so always putting an IV access is a nightmare for the child. Please do. So sorry for the glitches. So, but this child has no bleeding diastasis. So Dr. Satya, but has respiratory distress. So the IV access, maybe a central line was already put in the left femoral or somewhere. So first, before Dr. Satya chips in, Dr. Mihir will always try to get an IV dialysis access or some IV access there for a central line. And then Dr. Satya can modify it accordingly. So Dr. Mihir, what is your preference for this sick child who is having severe respiratory distress as an access for hemodialysis?
Yes, so it will depend upon the 2-3 things. The one, first of all, I think the PICU team has already put a line for giving the drugs. If that is on the femoral, then we
maybe left femoral.
Yeah. So femoral, then we have to go for the IJV, right IJV. So the issues are here is that the patient is having respiratory distress, heart failure, and the patient is drowsy. So if we put some, I have to give some sedation during the an analgesia to this patient putting. So that can decompensate compensate the patient, and the patient may go to the
So
even
if the
further.
child has a left femoral line for central line, which is a narrow gauge one, can we change the same limb as an hemodialysis access over a guide wire?
No, we will not prefer that.
Okay, fine. So for the time being, you are going for an IJP or the right side femoral also.
No, no.
Okay, fine. And Dr. Satya, any difference in opinion for this one?
No, no. As he said, always if you are doing dialysis, use that line only for dialysis. Don't
Okay,
give
fine.
any medication.
Fine.
Ideally, if you have facilities, expertise, better to put right IJV. If not, right femoral.
Fine.
And if you are putting right femoral, always catheterize the bladder, otherwise source of infection.
Correct.
You should be careful.
Fine. So always we need a central line for the IV infusions and everything for PICU child otherwise also. So better not to touch the line. Have a dedicated hemodialysis line which is used only for dialysis and not for giving regular infusion unless there is a dire emergency. So now finally planned for double lumen femoral catheter. Now the child is sedation now, a good sedation, otherwise we are unable to put this one. For IGP, as we all know that giving sedation is more difficult because the child needs to be at utmost standstill. For femoral, maybe with little bit less sedation, we can do some way. So what are the concerns, Dr. Mihir, regarding sedating this child with the distress with heart failure?
Yes, so as I already mentioned, the patient was drowsy, they're having respiratory distress, so whenever giving the sedation analgesia, patient may have further increased respiratory distress, and the poor GCS might lead to, during the procedure, patient may decompensate. So we do not want that, so for beforehand, we have to keep the airway, we have apprehend that emergency can arise. So a patient with respiratory distress will prefer to give the patient intubated and giving sedation and go for line, and after that, after dialysis, when you are moving the fluid and the respiratory distress is improving, we can rapidly extubate the patient. And the other option is that putting a patient, if the patient is cooperative, no respiratory distress, otherwise stable, not GCS is good, then patient is cooperative under local anesthesia. For older children, we sometimes do that.
So stabilize the ABC first and then go for the IV access properly after taking good care of the airways and ventilation. So now on first day of dialysis, the central line got blocked by the PICU team. So they need a line for regular infusion. So we have already put a dialysis line there, as you already told. So now can we use the dialysis line for regular use, Dr. Satya? We already answered it, but just repeat.
Better to not to use.
Better not to use because the first chance of infections are high, and then the dialysis line is being kept with a huge amount of heparin lock. So maybe a time we do mistakes and we flush the whole line with some normal saline or something, the whole neat heparin will go to the system, and that will cause huge amount of bleeding. So this girl now started on intermittent hemo, and for first day hemo, as I was asking Dr. Satya, what will be the precision? In very short, what will be the precision for first day hemo?
Yeah.
We'll have a full session on precision.
Yeah, as we discussed earlier, the child obviously requires intermittent hemodialysis. The only thing is, do gentle short cycle. First cycle should be gentle one, only for 1 to 1.5 hours. Our main aim should be 30% fall of urea. If you do aggressive dialysis, what happens? Urea will fall down. That causes cellular edema and dialysis disequilibrium syndrome. We should be very, very careful.
So then we are going to do for 1 hour session as for day 1 session. Maybe we do 1 hour of extra ISO-UF that we can be discussing in our hemodialysis session, etc. So that's fine. DDS part we will be controlling on next session. So it's important that both the teams, PICU team as well as our nephro team, they goes hands in hand. Otherwise, it is difficult to manage the child because it is not known many a times that what the PICU team is expecting from the nephrologist, and nephrologists also many a times have not having the baseline data. What is the problem in the, other than RFT, what are the bleeding profiles, what are the scenarios, what are the PICU team contemplating to give IVIG or other infusion within coming 1 or 2 days. That things to be discussed well among groups, to be sorted out and to come with a consensus. Otherwise, difference of opinion will remain. We have to come to a consensus decision. So that's why the child remains well for the better outcome of the child. So so for this one, we stop our session here. Our time is also over. So thank you for all the participants for present hearing. And if you have any doubt regarding decision making or the first session, you can always ask after all the sessions are completed. Okay? So can we close? Thank you. And and thanks to all my panelists, Dr. Mihir sir and Dr. Satya, for this pleasant outcome. Thank you.